This episode of the Nurse Practitioner Podcast is sponsored by Dakin's Wound Cleanser. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakin's Wound Cleanser. Just how powerful is it? Dakin's Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakin's. Hey NPs, were you unable to attend the NCNP Fall Virtual Event livestream? If so, we've got you covered with NCNP On Demand. You can view all of the recorded livestream sessions until January 18th, 2024, and earn 55 CE credits and 30.5 advanced pharmacology hours at your own leisure with NCNP On Demand. Register today. In this episode of the Nurse Practitioner Podcast, Dr. Josh Hamilton discusses precision medicine. Thanks for taking the time to chat with us today, Dr. Hamilton.
Really pleased to be here. Thank you for the invitation.
All right. Well, can you tell us a bit about your background and the work you currently do?
I can, yes. I'm like every nurse practitioner you've probably ever met in that we multitask really well and we want to be involved in everything. So I am no exception. In my formal full-time life, at this point, I'm a full-time academic leader. So I actually run a series of academic nursing programs, mostly online, although we've got several campuses at about 6 states, out of a university that's headquartered in the Twin Cities area. And then probably more interesting for this group is probably my clinical practice, and I've got a couple of them. I began as a private practitioner back around 11 years ago when I was moving home from Canada, where I had done a visiting professorship. So set up a very traditional practice at that time, and it's morphed a number of times over the last decade. Since about 2015, it is solely a concierge mental health telehealth. It's a telepsychiatry practice, and I've got about 250 patients that I take care of there. And that's sort of where the topic we're going to discuss today had its genesis, its evolution, at least in terms of my practice. And then as the pandemic was sort of getting a foothold in mid-2020, I joined an internet startup, at least it was at that time, that was really looking to leverage technology and artificial intelligence and the best of what was known about evidence and precision medicine kind of from a different vantage point to take care of adults with anxiety and depression across the country. I was one of the first nurse practitioners that was hired, and I've remained with the company as we've grown by about 6,000% over the last 3 years. So it keeps me plenty busy. And then, of course, I enjoy talking with people, and this podcast is no exception. I love talking about what I do. So thanks again for having me here.
That's very impressive. Thank you for sharing your background info with us. How would you define precision medicine, and what does it mean?
Precision medicine certainly has changed a lot. I mean, I think even that word that we threw out maybe 10, 15 years ago, at the time we were primarily focusing on, I think, probably oncology and really the treatment of cancer at that time, and trying to be more precise than just treatment as usual, which was basically poisoning a human until the cancer died or they did, whichever came first. Didn't feel very precise. So chemotherapy and radiation kind of led us into, gosh, there's got to be a more specific and directed way. And that sort of coincided with some of the great research that was going on in genetics at the time. And so the evolution out of that into different areas, not just cancers and oncology, but really to think about pharmacogenomics as an element of precision medicine, to say we can actually study, they call them biomarkers, but it's really pieces of our genetics and our genome that not only cause us to get sick or play a role in the evolution of illness. I think that's been a really important side of what we study and why this is a germane topic for health. But we can also use genetics and genomics to help determine how we approach an illness. And in my line of work, more often than not, that has to do with the prescription of medications. But you can also study precision concepts when you think about the types of counseling or psychotherapy and knowing how that works at the genetic level. So precision medicine at this point is really a broad, complex idea about taking the best of what's known, what the evidence is showing us in terms of causation, but certainly intervention, to say which medicines are going to work better for this individual based upon their genetics, perhaps, and certainly their circumstances. We're not ignoring the fact that we all live certain lives and in certain social circles with certain challenges, certain factors that we can either supercharge or ameliorate somehow. So a lot of that precision is to say we understand a patient, we understand where they live, how they live, what their challenges are, and then we drill in a little bit deeper to the level of the biology and the genetics to decide how to treat them when they experience a health challenge or an illness of some kind. So in its broadest sense, that's what precision medicine means today.
Thanks so much for explaining the term. Can you explain the difference between genetics, epigenetics, and genomics?
Absolutely. It's really important to get those terminologies correct. And I sort of alluded to it when we talked before. So, I think genetics at its heart is probably what most of us, at least, were aware of. I studied over 25 years ago, so it was still emerging. Honestly, we knew there was such a thing. But in terms of the biology and understanding it at that level of genetics and its impact upon health and illness and the evolution of illness and the treatment of illness really has to do with the genetic code. We all are given a full set of life's instructions from each of our parents. So we get 2 copies of everything there is to be a human and a specific human when we're conceived. So that at its heart is genetics, to think a little bit about how a cell comes together when we've got a sperm and an egg that unite and become a fertilized ovum. At that point, as we start to differentiate and develop, genetics is really driving that process. Where it got interesting for me, at least, probably in the 2010s or so, pretty early, is the understanding of epigenetics, which really is not the same as that hard-coded instruction set. That's genetics. Epigenetics has to do with some interesting features of the code, some additional letters in the genetic sequence at the very beginning and sometimes at the end of a set of instructions. So, for example, if there is a piece of genetics that codes for like the serotonin transporter gene, which is where a lot of the serotonin reuptake inhibitor antidepressants work, there is a little piece of code at the beginning of that that's called a promoter region. And that's an epigenetic code. And what it basically does is, based upon its status, whether it is active or not, it's either promoting the transcription of that gene, meaning it's actively being produced. That protein is actually in the factory and being produced by the factory, if you want to think about a factory analogy, or that particular epigenetic sequence is suppressed, meaning that gene is not currently being produced. Epigenetics was a really important finding because it helps us understand how that one fertilized cell, genetically speaking, knows when and how to differentiate. So every single cell in the body has the same genetic code. But when you think about what caused the cells in your foot to become foot cells, that's epigenetics. At some point, all of the other genes that hold the instructions for the heart or the brain or a fingertip or a human hair got suppressed. And they said, oh, we're destined, this little group of cells is destined to become a foot. So epigenetically, suppression of every other piece of instructions was accomplished so that just the foot genes and anything adjacent to becoming a foot was epigenetically functional or being transcribed. So epigenetics was really important because not only does it drive all differentiation in human life, it explains our evolution as a species, but it also gave us a really important lens into that nature-nurture argument. This is the nurture part. The way that the environment affects us and the way that the world pushes in on us, especially in mental health, my line of work, is really important, and that's an epigenetic function. So it really forms sort of one of the cornerstones of treatment, especially for psychotherapy and counseling. But when you think about some new ideas about medications and antidepressants and some of the newer psychotropics, really we're finding that the therapeutic effect and the long-term effect when those medicines work is truly epigenetic. And that's where genomics comes in. And it's really studying those two ideas together to form some sense of perhaps pharmacogenomics. What medicines, the pharmaco piece, how to prescribe medicines that interact either with the genome or the epigenome, or when you think about genomics in general, to understand risk and to understand indirect or direct interventions that have a genetic import or a genetic effect. So those three concepts hang really closely together, and they really do help us understand a lot more about what we're destined to be and the challenges we are destined. If you want to think about it that way, the hard wiring of our disease as much as our health is genetic. Epigenetically sort of decides how prone you are and how involved the environment is in helping you decide whether you're going to stay healthy or develop an illness. And then genomics really helps us determine how best to address those challenges or to promote resilience, or even thinking about some new concepts such as resilience and prevention. So they're really important concepts when you start to think about precision medicine.
We appreciate you breaking down those three concepts. How are these concepts linked to mental health care?
Really important linkages, and this has really been the focus probably for the last 15 to 20 years in mental health and in psychiatry. In particular, when you think about neurobiology, we have been trying to figure out the cause of mental illnesses for a very long time. And so there were some really important genome-wide association studies that were done probably back in 2013 is when this really got some momentum. So early on, the quest was really to think about something like one of the serious and persistent mental illnesses like schizophrenia or bipolar disorder, for example, to really try to determine which genes, heritably speaking, which ones do you inherit when you're conceived that run in families. We know bipolar, for example, is highly heritable. It does run in families. So we figured there must be a genetic cause. So a lot of that was searching for which gene or genes kind of go awry. And that was really frustrating work, I think, if I were a researcher trying to figure that out, because what they found fairly early is that it is seldom one gene that's causing an illness. It's a conspiracy of many genes. That concept is called pleiotropy, meaning that it's like the Bermuda Triangle. Several things go wrong all at one time to cause a persistent or serious mental illness. And we've since found that that's true for more common mental illness as well, like depression and anxiety, and to some degree, probably ADHD. So we have found that genetics plays an important role in causation. Where we sort of had to pivot was to say, could we use some of these same ideas, especially epigenetics, for example, to think about what causes a mental illness to reveal itself? The question was always, at some point in time, would Josh Hamilton always have gotten depressed and anxious when he was 21 years old? Were you always spiraling in that direction? Was that your biology sort of leading you inexorably in that direction? Or was it that you were vulnerable because you do have some of those genes that tend to all go awry at the same time? What does going awry mean? And that's where epigenetics came in, to say at some point the circumstances aligned, something about the challenges you were experiencing at that point in your life, the social support you did or didn't have, your nutrition, the stressors that were going on in your life, whether you were experiencing adjustment issues or maybe loss and grief, how all of that comes together and actually has the ability to change the epigenome. And what happens with a lot of mental illness is the genome, the epigenetic part of that, the promoter or suppressor region, gets methylated. The environment has the ability to cause methyl groups to attach to that part of the genome, the epigenetic code, and it actually causes genes to stop being transcribed. So in terms of what that means for mental health, that means that cells in the limbic system, for example, with depression and anxiety, when they are no longer transcribing actively, they tend to become atrophy. They shrink back away from each other. So those cells that are normally super close, basically shoulder to shoulder, just a micron apart, those suddenly live farther, and so they're not communicating efficiently, and they communicate with the monoamines. We've all heard about serotonin and dopamine and norepinephrine. That's what they use to reassure each other and calm each other down and cheer each other up. Those little cells in the limbic system give each other pep talks all the time. Epigenetically, if they're suppressed and they're not growing, they're no longer robust, they move apart. And at that point, they no longer communicate effectively, and reliably speaking, the mood goes down and anxiety goes up, especially with cells in that region. So knowing that leads us into concepts of genomics and precision medicine to think about in the short term. For 50 years, we've been saying, well, what we're trying to do with medication for mental health, like an antidepressant for depression or with anxiolytic or anxiety reducing properties, we've been saying, well, it's a chemical problem. It's an imbalanced chemistry. And that's not quite true. I mean, early on, certainly those medicines get up into those cellular communities and rebalance chemistry. So those cells are talking louder and talking longer, chemically speaking. But the beauty of it and the conundrum has always been, why is it taking a month to a month and a half to see anything really good from those medications? And the answer to that is, it's at that point, at about the 4-week period when you're on an antidepressant, that those epigenetics get reversed. And that's when the cells begin to grow back together. And by virtue of improved communication by situation, they're closer and they start to talk better on their own. That is the magic mark on the calendar where we actually see depression starting to move its way into response and remission. So knowing that really changed the way we think about the illnesses, at least those in the last, I'd say, 10 years. It's kind of earth shattering to know that knowledge is that new. So the next question was, genomically speaking, how to do that most efficiently, which interventions, which medicines to choose to cause that early improvement in chemical balance and the later improvement in cellular growth and the refurbishment of the system with the fewest side effects at the lowest doses, so that a patient would actually benefit from it and stay on it. So leveraging those three ideas simultaneously helped us better understand what causes you to be at risk for mental illness, what causes the environment to interact in such a way that you will express a mental illness, and then how can we leverage those concepts of precision medicine to actually give the best treatment to reverse that process. So that's kind of where the science is these days, at least in terms of precision medicine for mental health.
Very interesting. Thanks for sharing those insights. Next, what's your experience in applying precision medicine concepts in your practice?
I've got lots of great experience, and the story is sort of, it's not convoluted, but it was an interesting journey that I took, and it began about 11 years ago. And it was really having the sort of need to change my practice from more of a generalist practice to becoming a specialist. So I was trained early on as a family nurse practitioner and did primary care for a long time. And I was always the person engaging in mental health conversations, even with my primary care patients. So I was probably one of the earlier, just by lived experience, one of the earlier providers to say integrated care is really important, and it's really irresponsible for us to tease them apart in terms of taking care of the mind and the body. So I sort of was that person in the clinic always running us late because I was addressing mental health issues. From that to, it kind of in combination as I was pursuing my doctoral work, I also figured because I'm doing so much with mental health, I should actually get the formal training and certification, which I did at the same time. And that's been a long time ago. That was early 2000s. We had a bit of this conversation, sort of as I was becoming a psych mental health nurse practitioner. We knew a little bit, but not enough to do much with it. So as I was getting into practice and really becoming a mental health specialist, what was arriving on my doorstep was a population of patients that were really special. And I say that because they had tried taking straightforward treatments. They had been very much immersed in treatment as usual for their depression or their anxiety or their mood instability or their psychotic disorders. And they had failed. They'd become stuck. So they were often, on their fifth, sixth, or sometimes more medication trial. Often they were on a variety of medications. So polypharmacy was very common in my practice, and still not making progress, and had really never seen a full remission from their symptoms. So that's what my practice began to morph into. So I was searching for tools and doing a lot of reading about how to move the needle for treatment-resistant depression and treatment-resistant symptoms of various kinds. So it was by necessity that I sort of allowed one of the reps to actually come in. I had been aware in the transom of my mind of research going on at the Mayo Clinic in this area to really think about pharmacogenomics in particular. So it wasn't a new idea at that time, but it was very complex. It was very expensive. Only a couple of sites in this country were doing that kind of testing. And the report that came back, quite frankly, was almost incomprehensible to the practitioner at the layperson level. It was 85 to 90 pages long, very technical, hard to make sense of. So I knew it was happening. And what I didn't realize is back in about 2010, 12, 13, somewhere in there, that technology spun out to industry. And we had a couple of labs at that time that were actually offering psychopharmacogenomic testing. So I remember I had taken a meeting with one of the representatives and had a few sample kits, test kits, just kind of in the back room next to old charts. And it took a patient coming in, and I really was stuck with her. So I remember very clearly, it's been 12 years ago now. Really accomplished person, very intellectual. I think she was a drug representative herself for one of the drug companies that was vending a product for non-24 sleep for blind people. So very, very well educated, PhD. Autoimmune disorder, she had fibromyalgia, so a chronic inflammatory condition. Fibro always has a GI component as well as a mental health or anxiety component. She definitely had all of those things. She had an intractable depressive and anxiety disorder. I mean, literally had been on every class of medication under the sun, a variety of different agents in each class, just with a really confounding profile in terms of what moved the needle a little bit, maybe gave her a little bit of relief, even for a short period of time. The thing is, nothing ever really worked the risk benefit or the benefit side effect sort of equation was never well balanced. She always had side effects. Either they were serotonergic in nature or anticholinergic, depending upon what she was taking. So weight gain was an issue, sexual side effects, headaches, GI upset. And then just to add insult to injury, before I met her, she had been diagnosed with celiac disease. So she had this gluten intolerance as well. So she came in because she had seen a number of other providers and had been on all of these medication trials and was still very anxious and very depressed. So I did a psych eval and sat with her for an hour. And I remember coming away from that initial intervention just thinking, I don't know really where to go with her. And I was sort of struggling for the words to use and to even come up with a plan. And I remember taking a moment. I had gone out to look something up in a textbook, and I had walked by the room that had the charts in it, and there sat these two sample kits for genetics. And I thought, you know what, here's my Hail Mary. I'm going to get testing it. At least it'll buy me some time to think a little more clearly about her. So it was simple. It was much more simple than I expected it to be. You know, if you think about mainstream America and our fondness for 23andMe or Ancestry.com, just basic cheek swabs. That's all this requires, is a few cheek cells to get some genetics out of them. So I swabbed her cheeks and sent them off to the lab and told her I'd give her a call. Two things surprised me. One, the report came back very quickly. The samples went back overnight to the laboratory. The test was available to me in 36 hours, which really astounded me, given what I thought was really complicated technology. I guess things have come a little farther since the O.J. Simpson trial when we were running PCRs and RLFPs and whatnot. So it was fast. And the other thing that became so important to me was the format of the report. It was only maybe 8 pages long, and it was really well color-coded. It was iconic and graphical, and I immediately gravitated toward the more compatible medications for her. And nothing in that list of truly compatible medications had she ever tried. And everything else sort of appeared in the must have a dosage adjustment category, or in the really please don't use this because this patient's going to have side effects at every dose. So suddenly the world made sense to me. And when I presented it to her and we went through it, she cried. She said, it proves to me I wasn't crazy, that I was fighting biology, and that the side effects I was experiencing and the lack of improvement I was experiencing were not my fault. When you looked at everything she had tried, it really was never dosed properly or should never have been used based upon her genetic profile. And what we ended up with was choosing one of the medications from the compatible category at its lowest dose. And frankly, I was a little afraid of it. It had a fairly complex titration. It was Fetsima at that time, brand new, pretty hard on the gut if you're too ambitious with it. So I expected to hear from her. Honestly, I expected the phone to start ringing as she started taking the medication. And it didn't. She titrated up to an effective dose over about 6 weeks. And when she came in, I was impressed. So I practice measurement-based care. So we did get a PHQ-9, which measures mood, and a GAD-7, which measures anxiety. And not only was she at response, which is a 50% reduction in those symptom severity scores, she was approaching remission from those symptoms at week 7. So I figured there must be something to it. And it really led me to do a lot more research into what's going on underneath those tests. What is that technology? What are we actually studying? What are the receptors? And they're really fascinating. So it's worth a deep dive if you do work like this, even in primary care. If this is a place where you find yourself doing a lot of conversations, having a lot of discussions about mental health, depression, and challenges that have to do with anxiety or irritability or focus, it's really worth your time to learn more about this, because I will say that was not an isolated event. So this particular patient, she was a slam dunk right out the gate. It doesn't always go that well. But what I can confidently say after having done this for 10 years with a variety of patients for a variety of reasons, it still feels a little bit like finding a needle in a haystack in terms of finding that perfect medication. However, when you start to dig in there and go on that search, a test like this and having some pharmacogenomic information removes a lot of straw from that pile of hay. So the needle is less elusive. You do get closer much faster. And I think patients realize that and they appreciate it. So it's really been a tool for me, both to have those conversations and to help remove some of the stigma, that ability to depersonalize and to say, this is a medical illness like diabetes or high blood pressure. Imagine the look on your face if you were to go in to have your high cholesterol treated, and the treating practitioner said, well, just think harder, try harder, think your way out of that high blood pressure or that high cholesterol. It's that absurd to say there are no tools and there's no better conversation to be had about something that is as biologically based as depression or any other mental health concern for that matter. So it changed my entire practice. And I'd like to think that it's helped thousands of patients at this point who maybe otherwise wouldn't have moved forward. So, and I've got dozens of examples like that, but I think this is a good one.
That's a very powerful story. We appreciate you sharing that with us. Can you provide a few examples of how an NP might use precision medicine in screening, diagnosing, or treating patients with mental disorders?
I think we're all still hoping that someday there will be a way to use genetics and genomics and some of these concepts to just make the diagnosis. And unfortunately, the frustrating part is, at least for me, is we're not much closer to that than we were when I went into practice. So unfortunately, it's not possible to say you could use those same cheek swabs and send them out and they would say, this truly is those 3 genes that go wrong when a person develops major depressive disorder, and Johnny Q here in your office has those 3 genes. Unfortunately, we're not there. But I think all of us, my examples are all mental health, but there are other fields when you think about, especially prescribing medications, where you can use some basic pharmacogenomics, even if there's not a lot known about the pharmacodynamics, meaning that receptor for the medication. In mental health, we know there are some really clear areas in the brain, dynamically speaking, where genomics are important. When I talk about the limbic system cells, for example, knowing how the serotonin reuptake pump works, whether a person expresses a normal serotonin reuptake protein, that can really help you align a medication to a particular disease entity. If that's what you've diagnosed based upon a full eval and using the diagnostic criteria properly. Knowing more about something like the COMT enzyme, which is also genetically based. That's the enzyme, just to refresh your memory, that helps recycle dopamine in the prefrontal cortex. It's really important for mood, but also for executive function, focus and motivation and concentration. So dynamics can really help you in your line of work if there are dynamic genes or receptors for which there's consensus that making medication choices or adjustments based on those genes is clinically efficacious or shows you a clinical validity. However, even if you don't have dynamic genetic interactions, maybe in your field of work, pharmacokinetics, meaning that the way the body works on medications or metabolizes medications, are also really important. And we can all use those because I can tell you that, one, this may be new information to you, but it is not new information to the FDA. So when they study these medications, if something is known about pharmacodynamics or pharmacokinetics, it makes its way into the product information. So even just pulling a genetic profile on the cytochrome P450 genetics, so that you can understand, I'm about to give a medication that maybe has a narrow therapeutic index, that could be really different for each individual patient based upon their cytochrome P450 enzymes. So a typical medication has got to be metabolized by 1 or more cytochrome P450s. Knowing how well a person does that is highly genetic in terms of their metabolic efficiency. That will help you determine an appropriate dosing range for that individual patient just based upon those kinds of genetics. So I would say that with few exceptions, you're going to find at least limited utility if you've got a narrow index or if you've got someone who has shown a lot of side effects at a quote normal dose. It may be worth your time to study some P450 genetics to see whether their dose could be considered in the normal range published in your literature. It's not always. And in fact, when you look at the array of P450s and what it takes to metabolize a given medication, I would say upwards of 35, maybe as high as 50%, depending on the medication category, will have differing dose ranges just based upon genetics. So if you're going to use these ideas of precision medicine and pharmacogenomics in particular, understanding those pivot points, there are consensus panels. CPIC is one that I follow. That consensus group actually looks at those questions to say, of these thousands of genes we could test, which ones are showing a clinical validity or an efficacy if we use them to guide treatment. And that forms this general idea about how many genes you should test, which ones, And that would form a panel, if you want to think about it that way, of information that you can use. It's sometimes also called equipoise, which is just this collection of the best that's known about precision medicine and genetics in particular to make the best decision for that particular patient.
We're sure our listeners will find this information valuable. Finally, how can NPs learn more and get involved in this movement?
So I think one of the most important things is to ensure that you stay up to date, stay abreast with the newest information. I almost missed the boat by a year or two just because it was an interesting concept, and then I forgot to follow the research as it was coming in. And what I didn't recognize is that it was ready for prime time all of a sudden. So labs were starting to do this, and it was an important service. And now I guess there are probably half dozen or more companies that are offering this to us as providers, and insurance is actually starting to cover it. So I think knowing that and being on the cutting edge is really important. We owe that to our practices and to our patients. I dare you at this point to find a professional organization, a healthcare related organization, especially for us as advanced practice providers, that isn't including this topic. So if you go to conferences online or virtual events, or if you're going back out into the world and meeting your colleagues for destination conferences like we used to do, I guarantee you this topic is on the agenda. So if it's interesting to you, I think it's important for you to start to attend some of those sessions and learn what's going on in your particular field as it relates to precision medicine. And then I think reading the literature and visiting with industry. So if there's a particular vendor or a company that seems to be doing this work, invite them in. Now is the time to be having those conversations, to ask them a few questions. Are they incorporating the consensus work to make sure that you're practicing in an evidence-based way for precision medicine as well? A lot of companies will test a lot of genes, but you want to be a good fiscal steward of insurance dollars. So getting the test that gives you the most bang for your buck, for the dollar, and for the patient to move forward. And then also to figure out which company or companies are going to give you a report that makes sense to you and that you can use as that really important tool, that tether to have these conversations with your healthcare consumer, with your patient. Not all of them are created equal. So make sure it's a report that makes sense to you and that is usable in the time you have allotted to start to wrap this technology or this idea into the encounters that you're having with patients. So now's the time to catch up with the science, learn more about it, and then to see if there are particular industry representatives or vendors that could help you integrate this. I think now is a perfect time to be having those conversations.
Thanks again for your time today, Dr. Hamilton.
Thank you. It was a pleasure to be here.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at the Nurse Practitioner Journal, and on Twitter at TNPJ_journal. Thanks for listening. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks again for listening.